Hi, everyone. Thanks so much for joining us. ICSA Labs is pleased to present a webinar series on the 2015 edition testing requirements. During today's webinar, we're going to focus on the care coordination, clinical quality measure, and patient engagement criteria, and those map to criteria B1 through 9, C1 through 4, and E1 through 3. We also have some additional webinars that we've scheduled over the coming weeks, and we hope you'll be able to join us for those as well. My name is Michelle Knighton. I'm the Health IT Test Lab Manager at ICSA Labs, and I'm joined by my colleague Kevin Brown, who is our Certification Body Manager. Next, just a few housekeeping items. First, please mute yourself. We are recording the session, and we're going to post it online. That should be online by next week, and we will include the slide deck with that. And I'll be sending out an email notification to all of the registrants to advise when those are available. If you have any questions, please submit those using the chat feature in WebEx. First, I'm going to provide a really quick overview of ICSA Labs for those on the call who may be unfamiliar with us today. Next, I'm going to discuss just a general overview of issues that are relevant to the criteria we're discussing today, and that will be followed by a review of the testing requirements for criteria B1 through 9. Next, we're going to talk about the changes to the clinical quality measure criteria, as well as the delay in being able to certify on those. After that, we're going to walk you through the testing requirements for the patient engagement criteria, and then we're going to wrap up the day with next steps, including anticipated launch dates and our upcoming webinars. First, about us. ICSA Labs has been in business for over 25 years. We have one of the oldest and most extensive certification programs in information security. We were actually the first commercial lab in the world to receive ISO 17025 accreditation for information security testing, and we have continued that level of excellence into our healthcare programs. Our analysts are well-versed in HIPAA compliance and meaningful use regulations, as well as all required standards. And of course, we manage a number of security industry consortia. We have significant involvement in health IT testing and certification, and we do that for the ONC's Health IT certification program. We are also the test lab for Concert by HIMSS, and we're one of only two in the world, one of the only two labs in the world who have the designation of being able to test as part of the IT International Conformity Assessment Program. We have a number of accreditations, and these simply show our credibility. We have been assessed by third-party auditors to determine that credibility, and our two auditors are ANSI and NAVLab. So we have ISO 9001 registered for our quality management systems. We are ISO 17065 accredited as a certification body by ANSI, and then our test lab is accredited by NAVLab under the ISO 17025 standards. And of course, we're an authorized certification body and test lab for the ONC. Next up, just a criteria overview. So the categories in blue that you see here are the ones we're going to be discussing today. Now, there are some criteria that have optional requirements in them, but no criteria are fully designated as optional any longer. And if you remember, that's because that complete EHR certification designation has gone away. So we're going to talk about specific examples of those optional requirements per criterion a little bit later in our presentation. You're also going to discover that there is no longer the concept of domain-specific certification. So in the 2014 and even the 2011 edition program, you could receive either a complete EHR or a modular EHR certification in the ambulatory or inpatient domains. Instead, now with the 2015 edition program, you're going to be receiving a Health IT module certification, which is domain agnostic. However, there are some criteria that contain domain-specific requirements or maybe really more suited to one care setting over another. And so in those cases, just know that they'll be tracked at the criterion level by the test lab and certification body, and then those data elements will be reported to the ONC via their Open Chapel website. Just a really quick overview of the criteria type definitions. So we have 15 unchanged criteria altogether through the entire program, 26 that are revised, 19 that are new. And so That's important as we walk through the testing requirements so that you understand when things have changed, when they haven't, whether something's gap eligible, which means it's unchanged, or whether it's brand new. So for our purposes today, we have 5 new care coordination criteria, and you can see those on your screen. We have 2 criteria related to that common clinical data set. One is for creating, one is for receiving. We also have 2 criteria related to data segmentation for privacy, one for sending, one for receiving, and then we have the new B9 care plan criterion. We also have 2 new criteria, one each for clinical quality measures and patient engagement. So we have, for clinical quality measures, we have the filter criterion, and then for E3, that's our new patient health information capture criterion. Moving into the revised category. So we have 4 revised care coordination criteria. So B1, transitions of care, B2, clinical information reconciliation and incorporation, e-prescribing, data export. Some of these criteria names are going to sound very familiar to you. The reason they're revised is because they have new elements that weren't previously tested in the 2014 edition program, and we'll talk about those details. We also have 2 revised patient engagement criteria. So E1, that's our view, download, and transmit criterion, and then also secure messaging. So first up, we want to cover the care coordination criteria. So those are criteria that begin with the B category, so B as in boy, so that's B1 through 9. And I will let Kevin take it away.
All right, so for B1, previously this criterion was really split into 2, B1 and B2. It was create transitions of care and receive transitions of care. Now for 2014 R2, they did create a B8, which was essentially B1 and B2 combined into 1 criteria. But really what ONC has done for 2015 edition is they've molded B1 and B2 together, added a bunch of requirements, and then blew it up into several different criteria. But the primary criterion that maps back to B1 and B2 is now just B1 transitions of care. In the past, they addressed both the content and the transport. So the content including like the CCDA and the content that went inside, and then the transport, which at the time was direct messaging. Now the transport was strictly on the backbone using the direct backbone protocols. There was no requirements for the edge communication. So if you partnered with a HISP, the communication from the EHR to the HISP was not part of the evaluation per se, but the HISP to HISP communication was. On the content side, they were really focused on the common MU data set and a few additional fields. They also required to incorporate certain data fields out of a summary of care that you would have received. And there wasn't a lot of negative testing outside. If you guys are familiar with the direct certificate discovery tool, there really wasn't much in the way of negative testing. There's been a lot of changes for 2015. Like I said, they add a lot of requirements and split them across different criteria. Within B1, they no longer require any of the backbone testing. It is almost all strictly now, or it is now strictly for the transport, all edge protocols. So combinations of XDM, XDR, SMTP, POP3, and IMAP. Some of those are required, some of those are optional, or what they call alternative now. There's also requirements for tracking of MDNs and different types of MDNs, including successful ones, failure ones, and so on. There are a lot of negative test cases for sending and receiving messages, everything from failed authentication at the certificate level, invalid recipients at the SMTP level, and then that even translates down into the content where you're going to be required to validate incoming CCDAs. And there needs to be error notification. Now, they did specify that error notification doesn't necessarily mean an alert visible to the user in real time, but there are numerous negative test cases now where you'll be receiving files where there are problems in the XML, either in the structure or the content. Your EHR will need to, or your health IT module will need to detect those errors and notify the user either via an alert or possibly in a log file or something similar. And you'll also have to support both release 1.1 and 2.1 of the CCDA standard, where previously only release 1.1 was required. And instead of the common MU data set, They've switched the terminology to the common clinical data set. The fields are mostly the same, but there are some slight differences. And a big one that I think will cause a lot of surprise is the enhanced CCDA navigation requirements. So in the past, to navigate the CCDA, a lot of our products relied on a pretty simple XML style sheet that would include hyperlinks within a table of contents to navigate the document. That will no longer be sufficient to meet the enhanced navigation requirements. There are several new requirements specifically related to being able to display only one section at a time, actually making the other sections not visible, as well as setting preferences on the display order and the number of initial sections to display, and in addition to the quantity, exactly which sections to display. So those all kind of tie together. So those would be preferences that would be set by the provider, the user, not by the EHR developer. So you need to provide, if you're a developer, you're going to need to provide a lot of enhanced functionality to the end user for the navigation requirements. Those are sort of the major changes that you'll see with transitions of care. And then as we talk about some of the other criteria, you'll see some other changes as well. And next slide.
Thanks, Kevin. So next we're talking about B2 clinical information reconciliation and incorporation. So just want to point out these little icons in the upper right-hand corner. The D criteria, those are the privacy and security criteria that are also required if you're testing this criterion, and then also G3 through 6. And you'll kind of see that reference throughout all of the criteria slides, just to give you a bit of an orientation. For this criterion, a lot of the changes are related to standards. So previously, RX norm, NDC, and SNOMED, those were provided, but they were referential only. You didn't have to use them. Well, now you are required to use RX norm for med and med allergy lists. You're required to use SNOMED for problem lists. There's also a big push here that you need to be able to reconcile and incorporate CCDAs for both releases, just kind of like Kevin spoke about, releases 1.1 and 2.1. System testing and certifying to this criterion will need to reconcile and incorporate CCDAs for both. So the manual patient match permitted, so the ONC understands that a lot of health IT modules don't have sort of an auto match process, and that's okay. Manual patient match is acceptable so long as the received CCDA, so the one you're going to incorporate, so long as it can be matched to the correct patient record. And then the big new one that we see from 2014 to 2015 is that the system also has to be able to create a CCDA that includes the reconciled meds, med allergy, and problem list data elements, in addition to the data that was just incorporated from both of those CCDAs. So now there's a generation required, a generation of a patient summary list, the file for this particular criterion. You're still required to display, data from 2 different sources for reconciliation purposes, but everything else is brand new. Next up, e-prescribing. Lots and lots of changes here, right? So in the 2014 program, we just really focused on new prescriptions. We used NCPDP script version 10.6. We're still going to use that NCPDP script number or version. But let's talk about the new changes in the 2015 edition program. So we now have RX norm September 8, 2015 release that's required. Keep in mind that any of the standards that are required, and they specify a certain release, the ONC has said that you can use a newer release so long as this is the minimum. So if, in 2 years or even next year, a newer release of RX norm is provided, and I'm sure it will be, you will be able to use that if you would prefer. This also requires you to be able to send not just new prescriptions, but also changes to the prescriptions, cancellations, refills, fill status notifications. You also have to be able to request and receive the medication history information. So lots of changes there. This particular criterion, if you haven't had a chance to look at the test tool, you should. It's going to take probably a few hours to test would be my best guess. We might be able to get that down to an hour, but it really depends on how your system is able to interact with the test tool. So this is a really big change for the 2015 edition program. Now, controlled substances are still not required to be tested, so you can use them during testing if you want, so long as your system has met those, the DEA's EPCS requirements to do so. So I imagine most of you will not use controlled substances, you'll just use what's in the test tool, but just wanted to share that that is an option. So I wanted to talk a little bit about the version of NCPDP that supports sending and receiving the diagnosis element in the DRU segment. So if you're using ICD-10 codes with an additional qualifier, NCPDP supports that. However, this is not applicable to canceled or refill messages, and the reason for that is because the spec doesn't include the DRU segment in those messages, so of course you couldn't support the ICD-10 code with that qualifier. No DRU in canceled prescription messages or medication history information. The other new thing, but it's optional, is related to the SPIG segment. So the optional requirement is that you implement the structured and codified SPIG format version 1.2. You would need to let your test lab know that you were going to do that ahead of time because the test tool does not automatically test for that, so it's something that would have to be visually validated by your test lab. For the oral liquid meds, so the system now has to only provide milliliter units when it's an oral liquid medication. So you can't use CC anymore for writing prescriptions of oral liquid meds, so that's a pretty big change. The system also has to be able to insert leading zeros before the decimal if the amount is less than 1, and never to add trailing zeros after the decimal, and so that's a patient safety issue, those two items. So that's a new thing that we're going to be testing for. If for some reason the RX norm code doesn't exist for medication that you want to use, nothing prohibits you from allowing another code to be used. However, if there is a valid RX norm code, your system has to be able to accommodate that.
So for B4, CCDS summary record create. Again, this is one of the ones that's formerly a subset of B2, and that was the create functionality only. So now that they have separated content and transport, where B1 now deals almost primarily with the transport, the actual creation of the transition of care is handled now by B4. In the past, you only had to create a CCDA according to release 1.1, and the common MU data set was required along with the transport. Now you're going to be creating multiple types of transitions of care, and you're going to be using release 2.1. So before it was just a single transition of care / referral summary. Now it's the continuity of care document, the referral note, and a discharge summary if you're in an inpatient setting. This is one of those domain-specific requirements that Michelle talked about that's handled at the criteria level. So even though you no longer declare yourself an inpatient product or an ambulatory product, if you support inpatient settings, then you would need to generate the discharge summary and if you're testing B4. Again, they'll be using the common clinical data set, and again, there's no transport requirements for this one. This one's a little more straightforward. Next slide, please. For B5, this is the actual receipt of the summary record. So this is a subset of B1, which was the transitions of care received. Again, you only had to receive and incorporate a single transition of care referral summary formatted according to CCDA release 1.1. That was for each domain, by the way. You had to incorporate an ambulatory and an inpatient, regardless of the domain that you were testing against. And again, same thing, you're going to see a common theme here, common MU data set required, transport was required. Patient matching was not defined in B1 previously. In 2015, some of the key changes are you're not only going to be receiving and incorporating the transition of care, you actually need to validate, which goes back to the error notification, so you'll be performing error notification. And you'll need to parse multiple documents formatted according to both CCDA Release 1.1 and 2.1. So again, continuity of care document, referral note, and the discharge summary, which again is inpatient only. You also have the same enhanced CCDA navigation requirements we talked about with B1, and similarly, you have the common clinical data set required. It's probably worth pointing out at this point for both B4 and B5, those criteria are subsets of the current B1. So B1 is basically B4 and B5 with the transport requirements added. Testing to B1 officially does not automatically grant you certification to B4 and B5, but it's at the test lab's discretion or the certification body's discretion to possibly combine those. So it may be possible to get credit for B4 and B5 if you're also tested against B1. Next slide, please. This is a data export. Previously, it was referred to as data portability. Again, CCDA Release 1.1. Previously, you had to do an export summary for all patients. Now they've actually expanded that piece quite a bit. You need to be able to do an export summary for a single patient or for as many patients as selected by the provider. So they could select 10 patients, or they could select 100 patients, or they could select all patients. You need to support all of those scenarios. And instead of the common MU data set, the common clinical data set is now required. When you're running the report for the summaries, you also need to be able to support various date ranges, a relative date range, so anything from the prior month or anything prior to this date. You also need to support explicit date ranges. So you could say January 1st of 2016 to March 31st of 2016 and run that report on April 1st at 1 a.m. You also need to be able to specify the storage location. This is something that they felt the need to explicitly add. So it doesn't just export to a random location on the local hard drive or on an external server somewhere, but you need to provide the option of where the user can export that to. And you also need to limit the functionality of creating these records and exporting them to specific users. So it's not a feature that should be available to all users of the EHR. It needs to be limited to specific users of the EHR. That's a pretty significant change, and one that ties back to some of the security criteria that we talked about in our last presentation. Next slide, please. Now, B7 and the next one, B8, have to do with data segmentation for privacy. So one of the concerns that arose out of 2014 was there are certain types of practices, typically around behavioral health, substance abuse, and genetic information, where certain federal and state laws made adhering to some of the 2014 criteria a little more challenging. And there was a lot of discussion regarding how to handle that. So they introduced B7 and B8 to account for those types of scenarios. So what a product testing at B7 will need to be able to create a CCDA summary record tagged at the document level as being restricted and subject to redisclosure restrictions. The individual content of the CCDA does not need to be tagged. It's just the whole document. Again, this will be applicable to the work environments we talked about, and the idea is to be in accordance with the federal and state privacy laws. Must support the HL7 Implementation Guide DS4P Release 1 standard, as well as the CCDA Release 2.1 standard. Next slide, please. Now, on the receive side, it's a little bit more complicated. So, and that first bullet on the left should say receive a CCDA summary record tagged at document level is restricted. And again, the individual content is not tagged. When you receive a document tagged as such, you need to be able to support the sequestering of that document, basically meaning it's not stored in the same location or is accessible from the same screen as the other CCDA documents. And then you need to limit the viewing to authorized users. So when you think back to the couple criteria we were just talking about, and you need to limit the ability to create the export of summaries to limited users, you're going to have a similar thing here. You need to limit the viewing of any CCDAs received that have been marked as marked accordingly to certain users. Then you need to also support the ability to view that restricted document without incorporating any of the data directly into the EHR. So if your workflow for your system is upon receipt of CCDA, it's automatically incorporated into the appropriate patient record, you would need to not perform that process for documents tagged as restricted. Again, applicable to the same behavioral health, substance abuse, genetic information practices, and must support the same standards. Next slide, please. So for care plan, this one is a new one as well. This is to enable a user to record, change, access, create, and receive, that's a long list, care plan information using the care plan document template. So you need to be able to support the receipt of the care plan, but you don't need to reconcile it into your EHR. You do, however, need to detect errors in those received files. Again, CCDA release 2.1, and the care plan document template is very different from other parts of the CCDA standard. I would definitely recommend doing some more careful examination of this if this is a criterion you plan to pursue. We're not talking about the plan of care section within the standard CCDA document. This is a specific document type separate from just that section. It supports a lot more broader information. Some of the examples are education and social interventions. That list is a lot longer. And one change that they made, the standard that they're incorporating leaves the health status evaluations and then the outcome section and intervention section as optional. ONC is saying that these sections will not be optional. All right, next slide, please.
Okay, so next we are going to chat about the clinical quality measure criteria. And you will see for all 4 of these criteria, they are not going to be offered during the launch next month. We are waiting for Cypress to be updated. The expected launch would be the summer of 2016. Once we get more definitive information from the ONC, we'll certainly share that with you. So 2014 edition, what we saw was that you needed to be able to export Category 1 Release 2 files, and then they had some specifications depending on which domain you were certifying in on a number of clinical quality measures that you had to test. So in the 2015 edition program, you now see that it's Category 1 Release 3, so new QRDA spec there. And the number and type of clinical quality measures is up to you. So you could say, I want to do, 3 inpatient clinical quality measures. I want to do 1 ambulatory measure. You could do a combination. It's completely up to you. However, we do recommend that you consult any programmatic requirements around the specific number or type of clinical quality measures for your clients and what programs they might be participating in, because that will help you determine, maybe which CQMs you certify, both in the domain and the number. So the next change is the exclusion and exception data. So you have your IPP, your numerator, your denominator, and then we have our exclusions and exceptions. So that must now be codified. So the specific reason an action was performed or not performed to determine whether a patient does or does not meet the exclusion or exception requirement, that has to be in the QRDA, okay? Free text is permitted to be captured in addition to the minimum requirement to capture the data as a codified entry. You may not decide to do that. You may simply say, we're going to code it and that's it. But there is guidance from the ONC that free text is permitted in addition to that minimum requirement of making sure it's a coded entry. Also, users have to be able to create these reports at any time without the developer's assistance. So there was a lot of feedback to the ONC that they had to reach out to their vendor so that they could help them run these reports. That is no longer acceptable. The user has to be able to pull those reports on demand. So this is going to allow the provider or the hospital system to view and verify their clinical quality measure results, and that's for quality improvement, real time. So it's also going to give providers the ability to export their results to multiple programs. And some examples that they've given for those programs would be, of course, the one run by the CMS, different states and private payers and other reporting solutions. C2, CQMs, import and calculate. So in the current program, the 2014 edition program, you were given the option. So you could import QRDA Category 1 Release 2 data, or you could just do manual entry. And then again, you see the option to be able to, or the requirement on the number and type of CQMs that you were to test. Just like we saw in criterion C1, Category 1 Release 3 is now the standard that's required. And again, you can test any type or number of CQMs, so that is completely up to you. The requirement to import only, so you're no longer allowed to do that in manual entry. So that is going to streamline testing and certification by importing those QRDA Category 1 files. So it would avoid the need for systems to manually enter all that test data. And it's also going to promote quality improvement. So as well as data sharing between systems by providing that ability to import CQM data from other systems into your system in a very standardized format. We also have the expectation that your system is going to be able to deduplicate patient records. There's no prescription about how that should be done. You have the discretion as a developer to determine the most suitable method for deduplication, but it is a requirement here. Again, we're seeing the requirement that the user has to be able to create CQM reports at any time without your help. And then there will be additional rigor in testing. So when you've got a single patient included in the numerator, denominator, exception, and exclusion for how many different CQMs. So there's going to be a larger push towards that and increase the number of times that patient is used. C3, CQMs report. That was the CQMs electronic submission in the 2014 edition program, so just a slight change in the naming there. And this one required you to be able to export both Cat 1 Release 2 and Cat 3 Release 1 files. And again, we see the domain-specific requirements for the CQMs. Now you're going to have to, again, upgrade to Category 1 Release 3. Category 3 Release 1 remains the same. And so now we also have an option. So the user can create a data file for transmission of CQM data that is accepted electronically by CMS. So the requirements for CMS reporting are going to be published by CMS in various documents. One such document might be something like their CMS QRDA implementation guide. CMS will also indicate in their regulations and program guidance whether this optional provision is required for participation in any of its programs, like NACRA, for example, PQRS, things like that. This provision is optional because providers might decide to use technology certified to this criterion for reporting to programs that don't require it. So that's why it's optional. So again, this is a really great example of when you might want to survey your client base and see whether they are going to be participating in any programs that might require this. Actually, before I move from this slide, one other thing I wanted to note is the version of measure specs. So typically you would have told us as a test lab, hey, Michelle, I want to certify on the June 2013 release of the specs, and then another vendor might say I want to do the July 2014 release of the specs. That is no longer a requirement of certification in terms of having to test the same version of the measure specs. And so what I mean by that is you might say, these 5 criteria I want to certify in the June 2013 release, and these other 10 I want to certify in the July 2014 release. And you could always do that, but just wanted to specify that there's more literature out there from the ONC indicating that that is acceptable, even though they understand that typically you're going to certify in a single release. And so again, just making sure you consult any of your clients' needs and understanding which programs they're going to participate in so that you know which version of the measures you need to certify. Okay, C4. This is a brand new one, so lots of information here. So first, let's focus on the left-hand side regarding testing. So your system has to be able to record a number of things that are listed here, things like NPI, patient insurance, age, race, things like that. They have also specified that for some requirements and standards for some of those data elements. And those are listed here, and I'm not going to read them all to you, but for example, for recording the patient specs, that's the birth specs, that should be HL7 version 3. Race and ethnicity, SNOMED, again, all of these standards you can use a later version of, and that's per the ONC's policy that permits you to use a more recent version of certain vocab standards. For this first bullet here where you see all of these things listed, keep in mind that the system has to be able to record that information individually as well as at least one combination. So provider type and age, for example. So you have to be able to filter on that information per data element as well as that combo. And we saw that in the 2014 edition program for a number of different criteria as well, that each one and a combo. Let's see, QRDA Category 1 and 3 are the same releases of those specs required for all the other CQM criteria. Remember, that's Release 1 for Category 3 and Release 3 for Category 1, so they're just opposite. Now, when a provider registers for an NPI number, they're going to be required to select at least one provider type code from the code set. However, they could conceivably select more than one code. They have to always designate a primary code, but they can have multiples. So the NPI record for any provider will contain all of the codes that a provider selected, and it's expected that the CQM results could be filtered by any one of the provider's selected codes, right? Their primary, secondary, tertiary, and so on. So make sure that your system is able to filter on all of the codes that are listed for a provider. So for this certification criterion, it is intended that patient age is derived from the patient's date of birth, and that's so that a user could query for patients older than a certain age, younger than a certain age, or between, some sort of age range. So just keep that in mind when you're looking at the patient age. Also, testing is going to test for the site address, and that's the site address that bills for care rather than the mailing address of the provider itself. So keep in mind it's the billing address. It might be the same as the mailing address, but what you're focusing on is the site address for billing. The codes required are intended to present birth sex, and I think I mentioned that earlier. So it's not gender identity or reassigned sex, it is the patient's birth sex. The race and ethnicity codes, I just want to point that out. The CDC code system has over 900 concepts for race and ethnicity, and you are free to determine how the user interface is designed to accommodate that, including how many race and ethnicity values are displayed. So there's no default minimum number of visible selections. During testing, however, keep in mind that any one of those concepts could be picked by your test lab. So your system has to be able to at least accommodate them on the back end, and certainly you can filter out what's shown in the UI. Also for testing and certification, your system has to be able to demonstrate it can filter by a SNOMED code and any related codes in the problem list value by measure. So, and again, this is a criterion that won't be available until later this summer. Next, we have our patient engagement criteria.
So E1 is an existing criterion. A lot of the changes, there are a lot of new changes, but there's a lot of things that stay the same or close to the same. Previously, under 2014, every HIT module certified at E1 had to support WCAG 2.0 Level A accessibility requirements for patients and authorized representatives accessing their data. They've now made Level 2A optional. While it is optional, it seems to be pretty clear that ONC's intent is by the next version of criteria, Level 2A will probably become the minimum standard. But for now, it's optional, but you can use Level A as a path to eventually migrate to Level 2A. Again, as we talked about before, Common MU data set replaced by the Common Clinical data set. In 2014, initially you had to transmit via direct. Under R2, they did add some optional tests for edge testing. This is a very significant change for E1 going forward. Apparently, there were some implication struggles in the real world. Some of you may be familiar with that. What they've actually done here is they've changed the standard. Direct is no longer required in any format. There are two different transport methods now that are required. The first is via standard email. Under HIPAA, patients are permitted to, of course, send their own health data via an unencrypted transport. So at a patient's discretion, they may be permitted to send via standard email. But you must also provide a method to send via what's known as a trusted connection, which is actually addressed through D9. So when you're doing the trusted connection transport, you'll actually be testing according to the D9 criterion. Now, there's two ways to do the trusted connection. One would be message level encryption, such as encrypting in a document and sending it via regular email, or transport level encryption, which might be something like an IPsec VPN connection, an SSL connection, or since a lot of products already have this functionality built in, you could use direct messaging to meet the transport level encryption method as well. So you have to do both standard email and a trusted connection transport. Within trusted connection, you have the option of message level or transport level. If you're doing message level encryption, you must also support the ability to generate the hash of the message separately. So it's encrypted and integrity protected is what they're shooting for here. So that's a pretty significant change. Some products apparently already support both encrypted and unencrypted, but that is something that will definitely be required. The patient authorized representative requirement has not changed. That is still the same. The patient accessible audit log is also the same. They did make a few minor changes. I didn't have room to put that on here. I believe you now have to record the recipient in the audit log. Another significant change is being able to view the data based on date or date range. So when a patient or authorized representative logs into the site and they take a look at their data, if they want to look at their data from, say, okay, I had a visit on January 15th, I want to see the records from just January 15th. So any historical problems, medications, may not be included on that. If they want to be able to say, all right, I want to look at my record for all of 2015, or maybe from December of 2015, that functionality must be supported as well. These are brand new. Those are required. Another thing when viewing a record, I almost missed this. I didn't mean to skip over it. They did add requirements to be able to view lab test and diagnostic imaging sections to the data that's viewed. So if your system didn't already support lab tests and diagnostic imaging reports, then you will need to add that as well. Next slide, please. For secure messaging, it's mostly the same, send and receive between both the provider, or between the provider and both the patient and patient authorized representative. Ways that this can be met could be through a secure portal, email, mobile app. In the case of 2014, they really didn't distinguish between the different encrypted transport methods. Under 2015, similar to E1, there's that same trusted connection report. It needs to be either message level or transport level, and if it's message level, you need to generate the hash separately. So it is important to note that unlike sometimes when other criteria are incorporated, like with the security criteria, you may only have to do authentication once, and that applies to several criteria. For the D9 trusted connection, you must test it independently against D1, and then again test it independently against E2. It is required in both cases. They added one additional negative test, and that's to send from a provider to a non-existent user, and then the sender, which would be the provider in this case, must be notified that the message was not sent, delivered, whatever terminology you want to use. And that pretty much covers E2. Next slide, please.
Thanks, Kevin. So next we have E3, which is patient health information capture. And so this is our single brand new criterion in the patient engagement domain. So we have testing on the left side and clarification structured on the right-hand side. So the requirements here are that your system has to be able to identify, record, and electronically access patient health information directly and electronically shared, and so access it directly as well as electronically shared that information by the patient or their authorized representative. So the user has to demonstrate the ability to provide a reference. So, for example, providing narrative information on where to locate a specific health information document to patient health information. So the system has to be able to accommodate that. Also has to be able to provide a link to an external site where a health information document is stored. So, and then for the clarifications, this is replacing the old 2014 edition advanced directives criterion. They have also specified that the types of health information are very broadly interpreted. So the criterion doesn't seek to define the types of health information that can be accepted. And the reason for that is because it could be any type of document or health information from various devices or applications, things like home health or personal health monitoring devices, fitness and nutrition applications. Additionally, the health information has to be accepted, or shouldn't say has to be, but it could be accepted directly and electronically through like a patient portal, an API, or even email. So when they say types of health information could be broadly interpreted, that's what they mean by that. They've also provided us with a couple of definitions. So they told us that when they say the system has to be able to identify, it means being able to label the health information document. So classifying it, is it an advanced directive, is it, a heart monitoring, things like that. For referencing, they have specified that that just means providing narrative on where to find the document, and then linking simply means linking to an external website. Next, we're going to go over follow-up next steps, including webinars.
So we will be launching our prep packet and study guide information the week of 2/29. That's our estimated launch time for that. You'll be notified via email once that information is available if you're already on our mailing list. And then we'll be launching the program no later than March 31st. So prep packet and study guide, we're looking at next week as a likely time frame. Program launch, again, end of the month. And next slide. We have 3 more webinars coming up. March 10th, we'll be going over several more criteria, F1 through 7, G1 and 2, G6, and H1 through 2. And then the following week on the 17th, the certification body will be going over certification disclosure and transparency requirements. And then on March 24th, we'll be offering some more information on testing requirements for G3 through 5 and 7 through 9. Even though that's a much shorter list of criteria, there's a lot of information that will be covered during that webinar. Lot to talk about with those criteria. You can register for any of those webinars if you're not already at the URL provided there. Pre-registration is necessary. And next slide, please. And then here are some resources you can look at to find more information about some of the items we talked about today. The 2015 edition final rule from ONC, the approved test procedures, along with the certification companion guidelines, which I think many of you will find helpful. The Common Clinical Data Set Guide, you heard that mentioned several times today. If you're doing anything with CCDAs, that would be a good document to go and study. And of course, send links to the test tools. It's probably worth pointing out that in most cases, the test data that you'll be using for testing is stored within the applicable test tool. All right, that covers, I think, pretty much what we want to go over today. If you have any questions that you've not submitted yet, please submit those to Michelle Knighton via the chat feature, and we'll try to get answers to those questions.
Great, thanks so much, Kevin. So we do have a couple of questions for you, actually. The first question is from Brenda, and the question is, so does the 2015 edition B5 criterion not align with the B5 criterion in the 2014 edition?
No, it does not. It's actually a good question in that the numbering doesn't always line up. If you were to look at the security and privacy criteria, for example, you would see that previously accounting of disclosures was D9. It is now currently D11, but D1 through 8 line up is the same as what they did for 2014. So if you're familiar with certain criteria by the old numbering scheme, you'll need to be very careful to check because a lot of the criteria don't follow that same numbering scheme. And especially when you get into things like transitions of care, where it's really been broken apart against several other new criteria. So do familiarize yourself with the new numbering as you move through this process.
Great. Thanks, Kevin. And the next question is regarding criterion E3 from Catherine. And the question is, Kevin, you said the user has to provide a reference to the document. Oh, sorry, this is for me. This is criterion E3. So I said the user has to provide a reference to the document location. We understand that to be the ONC definition of user, where user is not necessarily a human user, it may be a system user. Also, the term narrative is not literal as long as the reference clearly defines the location that meets the criterion. So if the system user can create a reference that fully represents the location, that is compliant. So let me just move back to criterion E3 for us. So there's a couple elements to your question. So the first one I'll address is the term narrative. So narrative is not literal. If you look at this, the second bullet from the bottom on the right-hand side, it's just describing what the reference is, so providing narrative on where to find the document. So yes, if the reference defines the location, that would be the narrative of where to locate the document. And then your next question was about the user. So the user demonstrates the ability to provide a reference to the document location, and user is a very general term, so yes, the system has to be able to, the user using the system has to be able to access that reference information, and that might be a better way to state that. So thank you. I hope that clarifies your questions. If not, let me know. Okay, so the next question is regarding B6. Let me go back to B6 here for everyone. And so, Kevin, this is for you. Regarding D6 for a web application, how are we expected to specify a storage location for the data export?
All right. My apologies. I may have misspoke a little bit. So the ability to specify the storage location is up to the user, not up to the EHR. So what they're saying is you need to provide the ability for the user who's performing the data export to specify their own storage location, rather than having the EHR by default define the storage location. So if you were a web-based product, you know, a standard download command executed through the web browser, and then for applications, there's various ways to define the export location. But really, it's about the user's ability to specify the storage location. Great.
Thanks, Kevin. So the next question is from Catherine. There are a number of errors and clarifications in the CCDS test data. We have requested a transparent means to submit issues or questions to the ONC on these, and so far I've just been told to use email. Have you heard from the ONC that there will be JIRA or Google Groups or other transparent means for issue tracking of test data like there is for NIST tooling? And Catherine, I can share that I have not heard of anything. Our instructions have been for vendors and others who have concerns or questions to submit those to them via email. So unfortunately, I don't have the answer to that because I haven't heard that they're going to be doing that. The next question is for you, Kevin. Can you elaborate when you say create and parse version 1.1 and version 2.1 of the CCDA?
So for all the create steps, version 2.1 is required. For receiving steps, and the purpose is for backwards compatibility with 2014 edition certified products, you not only have to be able to receive and understand both the version 1.1 and the 2.1 versions of the CCDA formats or releases of the CCDA formats. The parsing really has to do with being able to ingest some of the discrete data that's captured in the XML. I say ingest kind of hesitantly because depending on the criterion, that may not actually be the right term to use. But for like error checking and validation, so when you look at some of the negative test cases that are available from the EDGE test tool, which is a tool that we'll be using for these tests, the negative test cases, they'll have like an invalid, medication header in the XML, and then they'll have maybe an invalid RX norm code within the content of the XML. So and that document will be sent in both a 1.1 and a 2.1 format. So you would need to be able to, as you're parsing the XML, recognize, okay, this is an invalid header or this is an invalid content. That's what the intent is there. I hope that's clear. If it's not, please send a follow-up question.
Thanks, Kevin. So the next question is from Clyde, and the question is there a way we can get some type of crosswalk of 2014 to 2015 to help us? And Clyde, I can share that in the prep packet that we're anticipating to offer beginning next week, we do indicate the differences between 2014 to 2015 at the criterion level. And you can find that same information here in our slide deck. We'll be posting those online. And certainly if that prompts more questions or you need anything else, don't hesitate to reach out. Okay, so the next question is for you, Kevin. It's for criterion E1. The slide says to create and parse version 1.2 and 2.1. I think that is meant to be version 1.1. So the slide states to create and parse version 1.1 and 2.1. Don't we only create version 1.1, but parse both?
I'll need to go back and double check on that one, but I believe the way I had it written was correct. What I can do, if we have your contact information, I can follow up with you on that. But I do believe it was both formats.
And the person who asked that question, I only see the name of your company, so if you could just send me a quick chat message and let me know your actual name, and assuming we have your info on file, I'm sure we do, we'd be happy to follow up after the webinar and just confirm that for you. So the next question is, this is all for stage 3 only, correct? And so that's kind of a big question. So where to begin? First, it's important for you to remember that there's no one-to-one mapping between the additions of certification criteria and the CMS stages of meaningful use. And what I mean by that is when you were in stage 2, stage 2, you can use a 2014 edition criterion, certified product, or maybe if a vendor comes in, next month and gets certified right away, you could use a 2015 edition certified product for stage 2. So there's no one-to-one mapping between, the stages of meaningful use and the ONC certification. So, and if you want to contact me offline, I'd be happy to point you to the resources of that. Essentially, you can find that information in the Certified EHR Technology definition. And in the newest release of the final rules, that's something that's published by CMS.
Michelle, I actually did confirm the answer to the previous question. It'll actually just be the create version 2.1 of the CCDA. The parse and the version 1.1, I believe, are a copy-paste error. My apologies. So it'll be create release 2.1 of the CCDA.
Okay, create 2.1, but parse both versions?
No, parse should be removed and version 1.1 should be removed. It should just read create release 2.1 of CCDA.
Great. Thank you for the person who asked that question, and we had a follow-up question from someone else who had the same question. So, and just so you guys know, we will update the slide deck when we post it online so that you have that information. And then there is one last question. This will be the last question we take. Can you confirm that we can use the 2014 edition certified products for stage 2? And yes, I can confirm that. So thank you so much, everyone, for attending today. If we didn't get your question answered, know that we will follow up offline and provide that. We'll also send out a link. We should have that sometime next week once we have the recording posted to our website along with the slide deck. So thank you so much, and we look forward to hearing from you in 2 weeks at our next webinar on March 10th. Thank you.